Hello and welcome to another intensivecarehotline.com live stream. I'm your host and my name is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com. And today I want to talk about ethical versus unethical practices in intensive care. And I'll give you some real life experiences. So just a couple of housekeeping issues. If you have any questions regarding today's topic, please type them into the chat pad. Any comments, you're welcome to type them into the chat pad. We'll go for about 45 to 60 minutes. I also have questions to go through that have come in during the week. So please feel free to engage if we have time. I can also take your calls, but it depends how much time we've got. So thank you for coming onto the show. And also anyone that's watching the replay, welcome to the show as well. Now, before I go into today's topic, a little bit about me, in case you're wondering what makes me qualified to talk about today's topic. I'm an intensive care nurse / critical care nurse. I have worked in intensive care / critical care for over 20 years. In 3 different countries. I have worked as a nurse unit manager in intensive care for over 5 years. I have been consulting and advocating for families in intensive care for over the last 10 years as part of my intensivecarehotline.com consulting and advocacy service. And I'm also the founder and managing director of Intensive Care at Home, where we are sending intensive care nurses into the home predominantly for long-term intensive care patients that are mainly long-term ventilated with a tracheostomy, but that are also ventilated via BiPAP, CPAP, non-invasive ventilation, seizure management, and some home TPN as well. So that's my background. So without further ado, let's dive into today's topic: ethical versus unethical practices in intensive care. Some real life experiences. So maybe going back to my time in ICU, which is not that long ago. As a matter of fact, I have worked at least a few shifts a year in intensive care, even as far back as 2019. And I'm working with intensive care staff every day. So I'm very much hands-on. I'm talking to families in intensive care all over the world every day. So I'm very much on the ball of what's happening in intensive care. As I was progressing in my career in intensive care and as I was managing ICUs, I became more and more aware of, what I believe is ethical and what is unethical in intensive care. As I then was starting to talk to families all over the world in intensive care who have loved ones in intensive care, I felt confirmed with what I was seeing in intensive care, but nobody wanted to talk about, not even families in intensive care, because they were scared of repercussions of, having repercussions from ICU teams if they speak up, because nobody was educating them about, what it all means. There was no opportunity for second opinions. There was no one putting content out there like I have done for the last 10 years at intensivecarehotline.com. where I pull the curtains of what's really happening in ICU and give my take on it. And as I said, as the phone calls kept coming in from families in intensive care all around the world, I felt confirmed in my opinion of what's really happening in intensive care currently. And it only probably became worse with COVID, with the pandemic. Anyway, let's start with some ethical practices. And, disclaimer here, because I have worked in intensive care for so long, most of the things that are happening in intensive care are very good. People go in there, they get treatment for critical illness, and they leave intensive care, and, people can move on with their lives. We don't hear from patients, we don't hear from families, it's all great. The challenge is when things don't go straightforward, when people stay in intensive care for much longer than anticipated, when things go wrong, when patients have complications, they have multi-organ failure, they need multiple levels of life support, and intensive care treatment takes much longer than anticipated. So let me just quickly start with some numbers, again, to illustrate. The average length of stay in intensive care is usually sort of anywhere between 2 days to 4 days. Average length of stay for a patient in intensive care, sort of 2 to 4 days. Not a long time. Patients tend to be in and out, move on with their lives, go to a hospital floor, or in some instances, of course, they may also pass away. So pretty much everything that I'm talking about here on my videos, as well as on the blog, is for anyone that stays in intensive care for much longer. Or intensive care teams might anticipate that this patient, a particular patient, might stay for much longer, because if that is the case, it actually represents an intensive care team's worst case scenario, which is to look after a patient indefinitely with an uncertain outcome. That's actually their worst case scenario, because then it's all about who has the control. Can intensive care stay in control? Can the family stay in control? Who's creating the narrative when someone stays in intensive care for much longer than necessary, or for much longer than anticipated? Not much longer than necessary, because it is necessary. It's more about much longer than anticipated. So if that is the case, intensive care teams are very quick in painting a picture of doom and gloom and negativity, and creating a narrative of, that even if your loved one was going to survive, they won't have any quote unquote quality of life, and that any treatment will not be in their quote unquote best interest. That, from my perspective and experience, is a very unethical approach, because what is quality of life? What is it? Well, it's something that you want to subjectively quantify. I want to stay in control what I think is a good quality of life, and I'm sure so do you. And you should not let intensive care teams sway you, move away from your opinion about what is a good quality of life for you, what is acceptable for you or for your loved one. But anyway, what is ethical versus unethical? Let's look at some ethical practices. Ethical practices is really about, making things transparent, educating family about what's really happening, not hiding anything, making sure that families and patients, if possible, are involved in the decision-making process. It's also about, helping families understand what they don't even know they need to understand. What I keep saying over and over again is that the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. And it's not ethical to hide things from families in intensive care, or from patients in intensive care, especially if they are awake, if they can cooperate. Treatment options need to be laid out. Prognosis needs to be laid out. A second opinion needs to be enabled, if that's what families and patients want. For example, a transfer to another hospital should be on the cards if the hospital where your loved one is currently at can't provide best care and treatment. Those are all ethical approaches. and really taking the time to talk to patients and families, and creating like a safe space for them, a nice and warm atmosphere. Unfortunately, many intensive care units nowadays are so short-staffed, whether it's doctors, nurses, allied health, that unfortunately intensive care teams have anything but time. It's it's all rushed. There's no more time for chit chat. If anything, it's like, well, tomorrow we got to have a family meeting at 3 o'clock, and we got to discuss the options, and you have to make a decision. These are statements we hear all the time, where families come to us and they say, well, I see you told me tomorrow afternoon at 1 o'clock I have to make a decision. And I go like, why do you have to make a decision? What's really happening here? And they say things like, well, they want us to give consent to a tracheostomy, or they want us to give consent that they can withdraw treatment and end the life for my family member. These are scenarios we hear all the time, and obviously, things that I have observed after having worked in intensive care for 20 years, almost on a day-by-day basis. And some intensive care units are better than others, but clearly the push is there to put more and more pressure on families rather than having empathy for them and working with them. Another ethical approach would be to really lay it all out for them, and lay it all out for families, and give them time to understand what's really happening. As I say, most of the time intensive care teams only tell families half of the story. They only tell families half of the story. Now, when we come in, we tell the families, well, we talk to our clients and say, well, have you considered this? Have you considered that? One approach for me is always to say, well, I'm going to ask questions that you haven't even considered asking. Very important that you understand that you don't know what you don't know. Just to give you some perspective, when someone works in intensive care, whether it's as a nurse or as a doctor, you have to go through rigorous years of training. Before I even could work in intensive care, I had to go through a basic nursing training. Then you had to get to basic intensive care training. Then you had to do a postgraduate critical care qualification. It takes years to practice, to be proficient in intensive care. So how can you as a family know what's really happening within a few days? It's not reality. It's not reality. Okay, so then let's look, and that's pretty much what it is in terms of ethical practices. It's not more than that. It's not more than that. It's fairly straightforward. Look after your families, look after your patients in the most ethical way. Don't make it dependent on, what you might see are resource constraints and so forth. Right? So let's look at other ethical practices, because I've got this document here that I researched, and it's actually from the American Medical Association, and I just need to bring it up. Just give me 1 second, please. I just got to bring up this document because it ties right in with what I believe are ethical practices, supposedly. Okay, so here it is. It's the AMA Journal of Ethics. AMA is I believe, the American, what is it? It's the American Medical Association, right? And they've put out a position statement, and it says, medical ethics, opinions on care at the end of life. Opinion 2.20, withholding or withdrawing life-sustaining medical treatment. The social commitment of the physician is to sustain life and relieve suffering. Where the performance of one duty conflicts with the other, preferences of the patient should prevail. The preferences of the patient should prevail. The principle of patient autonomy requires that physicians respect the decision to forego life-sustaining treatment of a patient who possesses decision-making capacity. Life-sustaining treatment is any treatment that serves to prolong life without reversing the underlying medical condition. Life-sustaining treatment may include, but is not limited to, mechanical ventilation, renal dialysis, chemotherapy, antibiotics, and artificial nutrition and hydration. There is no ethical distinction between withdrawing and withholding life-sustaining treatment. A competent adult and patient may, in advance, formulate and provide a valid consent to the withholding or withdrawal of life support systems in the event that injury or illness renders that individual incompetent to make such a decision. A patient may also appoint a surrogate decision maker in accordance with state laws. And this is something we deal with all the time. I mean, we are most of the time dealing with a surrogate decision maker. You know, if you call us up and your mom, your dad, your spouse, your child is in ICU, you are a surrogate decision maker. But the bottom line is this: you are in charge. You are in charge, not intensive care teams. Now, the position statement carries on. If the patient receiving life-sustaining treatment is incompetent, the surrogate decision maker should be identified without an advance directive that designates a proxy. The patient's family should become the surrogate decision maker. Family includes persons with whom the patient is closely associated. In the case when there is no person closely associated with the patient, but there are persons who both care about the patient and have sufficient relevant knowledge of the patient, such persons may be appropriate surrogates. Physicians should provide all relevant medical information and explain to surrogate decision makers that decisions regarding withholding or withdrawing life-sustaining treatment should be based on substituted judgment, what the patient would have decided. Let me repeat that: what the patient would have decided, when there is evidence of the patient's preferences and values. In making a substituted judgment, decision makers may consider the patient's advance directive, if any, the patient's values about life and the way it should be lived, and the patient's attitudes towards sickness, suffering, medical procedures, and death. If there is not adequate evidence of the incompetent patient's preferences and values, the decision should be based on the best interests of the patient. What outcome would most likely promote the patient's well-being? But even there, I would object, that in this day and age, most families that we work with, they all want their loved ones to live, and they say that my loved one would want to live. Now, spoiler alert here. With services like intensive care at home now, patients can choose to go home with intensive care at home and have quality of life or quality of end of life at home instead of intensive care, right? So, the trajectory has really changed in intensive care in particular, where, 20 years ago, intensive care units would have said, well, a patient in intensive care has two options. First option is to recover and go to a hospital floor. Second option is to die. Well, in 2023, there is another option with intensive care at home. Long-term intensive care patients can go home and have quality of life or quality of end of life in some situations. Let's go back to the Medical Association's Journal of Ethics, and let's carry on with the article. Though the surrogate's decision for the incompetent patient should almost always be accepted by the physician, there are 4 situations that may require either institutional or judicial review and or intervention in the decision-making process. 1, there is no available family member willing to be the patient's surrogate decision maker. 2, there is a dispute among family members and there is no decision maker designated in an advance directive. 3, a healthcare provider believes that the family's decision is clearly not what the patient would have decided if competent. And 4, a healthcare provider believes that the decision is not a decision that could reasonably be judged to be in the patient's best interest when there are disputes among family members or between family and healthcare providers. The use of ethics committees specifically designed to facilitate sound decisions making is recommended before resorting to the courts. Right. Okay. Well, I want to talk about ethics committees here, and I probably will designate a full live stream about ethics committees in intensive care in the future. Now, ethics committees, from my experience, after having worked in intensive care for so long, and after talking to families all around the world in intensive care for the last 10 years, ethics committees, from my perspective, are, for lack of a better term, death committees, right? Ethics committees are held within hospitals, talking themselves up that they are ethical, and yet 9 times out of 10, they always decide that it's quote unquote in the best interest of a patient to die. Now, bear in mind, the people on ethics committees are hospital employees, not going against what their employer wants, which is often empty ICU beds because there's so much demand. And also, the shorter an ICU stay, the more money the hospitals often make. So, clearly there is a conflict of interest from a hospital perspective to hold ethics committees where there's only hospital employees on the committee without any outside influence, right? We have been, part of ethics committees with some of our clients to have an outsider view with much success, it says before resorting to the courts. Well, the reality is that what are families going to do if the ethics committee decides that it's quote unquote not in the best interest for a patient to live? Especially again nowadays with services like intensive care at home, what's the problem with prolonging life at home if that's what people want? Now, the article continues. When a permanently unconscious patient was never competent or had not left any evidence of previous preferences or values, since there is no objective way to ascertain the best interests of the patient, the surrogate's decision should not be challenged as long as the decision is based on the decision maker's true concern for what would be best for the patient. Physicians have an obligation to relieve pain and suffering and to promote the dignity and autonomy of dying patients in their care. This includes providing effective palliative treatment, even though it may foreseeably hasten death. Even if the patient is not terminally ill or permanently unconscious, it is not unethical to discontinue all means of life-sustaining medical treatment in accordance with the proper substituted judgment or best interest analysis. Now, I strongly disagree there. And I think that even the AMA statement here does not act in a patient's best interest. Promoting dignity and autonomy of a dying patient is making sure his or her wishes are fulfilled. And again, it says effective palliative treatment, even though it may foreseeably hasten death. Strictly speaking, you could argue that hastening death is euthanasia. If you look at the definition of euthanasia, it says it is deliberately hastening death. So people will have very different points of view from that perspective, depending on where they stand morally, ethically, maybe on a religious or spiritual level as well, which the article doesn't point towards. Why is the article not pointing towards people's spiritual beliefs, religious belief, moral beliefs, ethical beliefs? It doesn't talk about that, which is very concerning. Okay, let's move along. Opinion 2.225, optimal use of orders not to intervene and advance directives. More rigorous efforts in advanced care planning are required in order to tailor end-of-life care to the preferences of patients so that they can experience a satisfactory last chapter in their lives. There is need for better availability and tracking of advanced directives and more uniform adoption of form documents that can be honored in all states of the United States. The discouraging evidence of inadequate end-of-life decision-making indicates the necessity of several improvement strategies. Now, I can tell you, even though this is an article from the United States, I can tell you that, in other countries like Australia, the UK, they will have very similar statements. I read through the relevant statements of intensive care or medical authorities. They're very similar. Of course, local laws slightly change. I will post a link to this article if you give me 1 second. I don't want to keep you in the dark what's in that article. Just give me 1 second. I will post actually a link to this article. My apologies if I have dropped out for a second. Here is a link to the article. I posted that in the thread there. Okay, so let's move on with the article. Patients and physicians should make use of advisory as well as statutory documents. Advisory documents aim to accurately represent the patient's wishes and are legally binding. Legally binding under law. Statutory documents give physicians immunity from malpractice for following a patient's wishes. If a form is not available that combines the two, an advisory document should be appended to the state statutory form. Next. Advisory documents should be based on validated worksheets, thus ensuring reasonable confidence that preferences for end-of-life treatment can be fairly and effectively elicited and recorded, and that they are applicable to medical decisions. Next. Physicians should directly discuss the patient's preferences with the patient and the patient's proxy. These discussions should be held ahead of time wherever possible. The key steps of structuring a core discussion and of signing and recording the document in the medical record should not be delegated to a junior member of the healthcare team. Now, I agree that physicians should directly discuss the patient's preferences with the patient and the patient's proxy. I could not agree more with this. The reality is that what we're seeing is anything like it. You know, for example, we were working with a client recently who didn't speak English, and the intensive care team didn't bother even getting an interpreter for these patients and telling the patient about the intensive care team's plan. That was anything but ethical. It was very unethical. Okay, let's carry on in the article. Central repositories should be established so that completed advisory documents, state statutory documents, identification of a proxy, and identification of the primary physician can be obtained efficiently in emergency and urgent circumstances as well as routinely. Well, again, this sounds all good on paper. When we deal with this in practice, it's much more difficult getting documents either from the hospital or from families. It's not always clear cut. It's not always readily available. It's very challenging, actually. But I can only suggest to families as well, have your paperwork in order. Next. Healthcare facilities should honor and physicians should use a range of orders on the doctor's order sheet to indicate patient wishes regarding avoidable treatments that might otherwise be given on an emergency basis or by a covering physician with less knowledge of the patient's wishes. Treatment avoidance orders might include, along with a DNR order, which stands for Do Not Resuscitate order, some of the following: full comfort care only, FCCO, do not intubate, which is a DNI, do not defibrillate, DND, do not leave home, DNLH, do not transfer, no intravenous lines, no blood draws, no feeding tube, no vital signs, and so forth. Well, one common new order, do not treat, is specifically not included in this list, since it may unintentionally convey the message that no care should be given and the patient may lose the intense attention due to a dying person. FCEO, which stands for full comfort care only, serves the same purpose without the likely misinterpretation as with DNR orders, do not resuscitate orders. These treatments avoidance orders should be revisited periodically to ensure their continued applicability. Active comfort care orders might include allow visitors extended hours and inquire about comfort care twice daily. Right, so this is all looking fantastic on paper, and I'm glad that there's at least something publicly available, but the reality looks very different in contrast, and it actually looks very black to me, where families are often being bullied. I can give you numerous examples where families have been bullied to agree to basically let their loved one die, right? I unfortunately have no other word for it but bully. So we have so many phone calls every month where families tell us, well, tomorrow at 1 o'clock, my loved one will be taken off life support. The ICU team says they can make a unilateral decision, which is not true. And if families, feel intimidated by that, they might give in, and they might lose their loved one by not knowing their rights, and that is highly unethical. So far, and I've just published a podcast in the last couple of weeks with one of our clients that we saved from such a situation that I just mentioned, where intensive care teams tell family whether there are no other options but end of life, and it's in your loved one's best interest anyway. So have a look at the podcast that we just published a couple of weeks ago. I'll post a link here, where we have actually done an interview with one of our clients, including the patient who was a patient there and then, where the ICU team says, well, he won't survive anyway. Well, about 15 months later, he's sitting on a podcast with me, saying, how grateful he is that his family found our organization, and that we could intervene and save his life, So other unethical practices are simply that, intensive care teams won't release medical records on time. Unfortunately, this is also something we're dealing with all the time. We want to review medical records, and the families ask us to review medical records, and then intensive care teams are not releasing them as quickly as they need to release them. Again, that is highly unethical. Highly, highly unethical. And why do they do that? Do they have something to hide? That's a question you should be asking yourself if you can't access medical records. Other unethical practices are that ICU teams, tell families, well, tomorrow we need to do a tracheostomy, and then we need to do a PEG tube as well, because it's best practice to do both at the same time. Well, I can assure you, from having worked over 20 years in ICU, a PEG tube is not necessary for a long-term ventilated patient in ICU if there's a chance of weaning. If they can't be weaned, it's a different story, because, if they're definitely unable to be weaned, they probably do need a tracheostomy and a PEG tube. But in the short term, you don't necessarily need a PEG tube. You might only need a nasogastric tube, but this happens all the time, especially for our audience in the US, where once your loved one has a PEG tube and a tracheostomy in the US, they can send your loved one to LTAC. Now, I can tell you, I just had an email from a client this morning where, exactly that happened again, what we've been saying over and over again. So patient was discharged to LTAC, and within 4 or 5 days, they bounced back to ICU because LTAC simply are not equipped to look after intensive care patients or after ventilator and tracheostomy patients. So patient went into LTAC, and within 4 or 5 days bounced back into ICU. Now, here's the bad news. Like I have said on countless other videos, when patients go from LTAC back to ICU, the ICU that discharged them in the first place does no longer have a bed available for them. So that means a critically ill patient goes from ICU to LTAC, which they should have never gone to in the first place. Within 4 or 5 days, they're bouncing back into ICU. The ICU where the patient came from no longer has any beds available. And then they're going back to another ICU. That is madness. That is insanity. And the reason I'm saying that is simply, a patient in ICU needs consistency of a team. They need consistency of a team and not bouncing from facility to facility, which is exactly, again, what's happening in this situation. Again, we've seen it so many times, unfortunately, right? And by a patient bouncing from facility to facility or from hospital to hospital, it is not conducive for a recovery. Patients in intensive care need stable teams around them that get to know a patient so that they can help them step by step to recover, you know. So I'm just going through to this email from this morning about from my client. Just give me a second. What does she say? I'm just reading this out. So here I can actually read out an email from a really unethical ICU and what's unethical practices. So this is an email from a client. Since we last spoke, my mom has had a few more ups and downs. Getting my sister to understand that the hospital didn't have good intentions for my mom proved harder than I realized. Suppose she was in denial, but everything I had warned her of, she had to find out the hard way at my mother's expense. This is obviously coming after, I've spoken to the client a few weeks ago that what was about to happen. For example, after we spoke about the unlawfulness and having the nurse overhear, that conversation had changed the direction of the ICU staff and began to see a change. Mom started to receive better care and started to show signs of improvement. What happened there when the client first reached out to us? Again, similar to other clients, the ICU literally wanted to kill the patient and saying, well, tomorrow at 5 o'clock, we're going to withdraw life support. This is exactly what's happened. And then we intervened there successfully. Once again, we have never intervened unsuccessfully unless families don't follow our instructions. I can assure you, we've always saved patients to not have life support withdrawn every single time, as long as families follow instructions. If they're not following our instructions, then we can't help them. So for example, after we spoke about the unlawfulness and having the nurse overhear that conversation had changed the direction of the ICU staff and began to see a change, Mom started to receive better care and started to show signs of improvement. While she was still at, and I'm not going to read out the hospital name, my sister and the doctor had decided on an early surgery, a tracheostomy. I was against this for a couple of reasons. During my mother's care, they had gone so far as to remove her of the fluids, and without my sister's approval, had put her on hospice. This resulted in my mum becoming very ill, showing signs of dehydration and just overall failing organs. Now, you can't tell me that this is ethical, what my client describes here. We had successfully intervened with your help, and at that moment, and that's when the doctor had placed her back on full fluids, and 3 days later, she was in better spirits. She was beginning to communicate well, be very alert, smiley, even laughed. The very next day is when they decided to do the tracheostomy without allowing my mum to recover and at least spend the day catching up on fluids. I was also against this because I didn't feel like it was a good idea to perform the surgery in this particular hospital. Again, I'm not going to mention the hospital here, considering the possible complications and the unstableness overall. Against my advice, they performed the tracheostomy surgery, and just like I suspected, my sister wanted to transfer Mum to a long-term acute care facility. Upon arrival at this new long-term facility, my mother wasn't there for even 36 hours before she took a downward spiral very quickly, to the point where she was rushed back to ICU in another hospital where she is now residing. It's absolute madness sending patients to LTAC, as is again evidenced here by this email from our client. And it keeps coming back that those are extremely unethical approaches from ICUs. Having said that, the system in the US in particular is screwed in the way that, LTACs are there, unfortunately, and ICUs are now designed to do a tracheostomy and a PEC tube as quickly as possible, and then patients are being sent to LTAC, and it's just highly unethical. Patients bounce back all the time. LTACs are not designed to look after someone on a ventilator with a tracheostomy. It shows over and over again. So what's the alternative for anyone that is in a situation like that? Well, the alternative is intensive care at home, of course, especially with a trach and a PEG, or long-term ventilation and a PEG tube. The alternative is intensive care at home. Go and have a look at intensivecareathome.com. I'll just post a link there. Now, we are currently operating with intensive care at home in Australia, mainly all major capital cities and rural areas. We are also starting in the US very soon, probably starting in Texas. You will hear more from me in the next few weeks. Now, what is intensive care at home? We're basically an intensive care substitution service where we send ICU trained or critical care trained nurses into someone's home for predominantly ventilation and tracheostomy patients, adults and children, but also for patients that are non-invasively ventilated without a tracheostomy, or patients that are not ventilated but have a tracheostomy. So we do both, right? And also home TPN. Okay, and if you're watching this and if you are in Australia, we are NDIS funded, TAC funded, DVA funded, ICARE New South Wales, as well as NIISQ in Queensland. So please contact us with any help. Also, the Department of Health funded. So please contact us if you have a loved one in intensive care and you're looking for intensive care at home, or if you're at home already and you need more support because you're realizing that whatever supports you're having is not intensive care trained and you're struggling keeping your loved one at home, or you don't have staff, please contact us as well. And if you're in the US, please contact us as well. We can point you in the right direction. So, so now my mom, I'm going back to the email from my client where she's saying, now my mom is battling thrush and other infections. She's now on antibiotics and steroids to help her lung condition. The doctor had stated if she had no signs of improvement, they would stop treatment on Saturday. Unbelievable. So again, criminal act of the ICU to even suggest that, just by what we said before with the AMA statement, because it will, we've looked at the state laws for this particular client. The client is actually in New Mexico. And again, withdrawing treatment without patient or family consent is illegal. It's a criminal act, right? So I hope that illustrates once again what's ethical and unethical. Another unethical practice that we see all the time is that patients have a DNR or an NFR form on their file without patient or family consent, because again, ICUs think that it's quote unquote in the patient's best interest to not have resuscitation. So DNR stands for do not resuscitate, and NFR stands for not for resuscitation. Highly unethical. And unfortunately common practice, so you got to watch out for that. Also, another unethical practice we are seeing all the time is with the tracheostomy as well. You know, patients are being told, or families are being told, well, tomorrow we need to do a tracheostomy at 3 o'clock, you know, and you know, and families haven't even had time to do their research, especially in the US. Families then give consent for a tracheostomy, and the next thing they realize is the patient will go to LTAC, especially in combination with a PEG tube, right? So again, highly unethical, especially if families have not been educated about their options, you know. So yeah, highly unethical practices. You know, we have seen many times now, oh yeah, I've given consent to a tracheostomy and a PEG, and next thing they know, within 24 hours, they're trying to send patients to LTAC, and then these things happen, what I just showed you before with our client, where the patient went back to LTAC within less than 36 to ICU, where the patient went from LTAC to ICU within less than 36 hours, just as we predicted, right? So that's all good. Well, it's not good, but it gives you more insights about what's unethical, what's ethical, and what to do. Well, what to do if you are confronted with these situations is to reach out to us, because again, we can help you. We can educate you on your rights. We can give you that second opinion. We can hold intensive care teams accountable as professional advocates and consultants. So please, contact us if you are in a situation like that. Now, I just need 1 second because I just need to respond to a text to one of our staff. And then I will carry on. Okay, so let's go back to a couple of questions that have come in this week that we can carry on. And I'm sure most of those questions will tie in with what's ethical and unethical anyway. I should also say that, a lot of what I'm doing nowadays, is a result of me being challenged by many unethical situations that I've been involved with in ICU. Myself, I could give you many examples, and I've spoken about some of these situations on some of my blog posts, some of my videos, but just, again, to illustrate some of the situations that I've been confronted with over the years. The most vivid one was maybe, 10, 12 years ago, when I still had a full-time job in ICU, where, I came to a shift. I was looking after 62-year-old man who fell off the roof just, 24, 48 hours before he went into ICU. I was looking after him. He was dying. He had significant brain damage. He was very unstable. And we knew he was dying. It was actually a real, not a perceived end-of-life situation. And I looked after him on my first night shift. It was just the day he came into hospital. We were just trying to, work with the family and trying to work out what their preferences are with end of life and so forth. And, family was waiting for the brother to come in from overseas. And at that stage, it looked to me like the ICU wanted to work with the family to get their wishes fulfilled, and having family come and say their goodbyes. And then I remember coming onto the next night shift, the night after, where at the beginning of my shift, the ICU consultant came to me and says, well, in a couple of hours, at 10 o'clock, you're going to extubate the patient, which to me was similar to a death sentence. He would die once we would take the breathing tube out. And I said to the doctor at the time, without even thinking, I said, well, if you want to extubate this patient at 10 o'clock, you can do it yourself. I'm not going to do it because the family isn't ready. And I'm not participating here in a quote unquote execution. If you want to do that, do it yourself. And he said to me, so you are refusing my orders? And I said, that's exactly what I'm doing. And I went back to the nurse in charge and I said, well, you can either reallocate me to another patient or I'm going home. I'm not having this, And lo and behold, of course, there was not much they could do. And I was looking after the patient the whole night. And of course, they stayed clear of extubating the patient because the family was still waiting for the brother to come in from overseas, brother of the patient, and the patient then would have passed away probably the day after. I had a day off the day after. But what I also remember clearly, again, hospital sort of demands. It was on a Sunday night. It was a Sunday night shift. I remember that. And Mondays, surgery starts again, and ICUs need beds. And, and this particular doctor, I believe, had no appreciation of, families needing time, families needing closure. This was, sort of, I believe, lack of bedside manners, lack of insights into people's emotions and so forth. It was purely driven, a decision driven by bed and financial requirements. I mean, that was one situation that I vividly remember, but there were other situations that I vividly remembered where, for example, I looked after patients in intensive care that had a DNR, young patients in particular. There was a 22-year-old and there would have been a 41-year-old lady, 22-year-old young man, 41-year-old lady who had DNR orders without their knowledge, without their consent. And when I challenged it, I was told, well, the medical director of the ICU wants it like that. And I said, well, I don't care. This is breaching all laws. It breaches all ethics, breaches anything under the sun, And I do believe that this particular intensive care unit that I worked at and challenged all these practices has changed some of those practices because of me challenging them and talking to other people, talking to stakeholders within the ICU. So, but at the end of the day, I also realized that the biggest difference I can make is working outside of the ICU and doing what I'm doing now, because that has a bigger impact. So now let's answer one more question and then we'll wrap this up for today. There's a question from Nikki. Hi, my son is 20, is minimally conscious and on a ventilator. He's at home. His respirator company has minimal engagement, mostly to change ventilators. We are in Sydney, Australia. I was wondering if your company offers any support for the weaning process at home. Thank you for your time, from Nikki. Yes, absolutely, Nikki. If you are watching this, you should contact us at intensivecarehome.com. I presume if you're talking about your son is 20, he would be NDIS eligible. We can help you get the funding for intensive care nurses at home. What you will need, as well as you will need an NDIS support coordinator that can help you with that, but we have the NDIS support coordinator on our books, and we can help you walk you through the process so that your son is well looked after. If he doesn't have intensive care nurses at the moment, he's at risk of dying, and I'm not exaggerating here. The reason I'm saying that is, we had 2 clients in the past that were only funded for night shifts. They both were having a tracheostomy. One was ventilated, one was not ventilated. We knew that their lives were at risk when we left after a night shift. And just as we predicted, both of those clients passed away during the times when intensive care nurses weren't present because of lack of funding. And unfortunately, medical emergencies could not have been managed or were not managed by either family members or support workers, or in one instance, even a general registered nurse, right? So that's how significant this is, Nikki. I think you need to reach out to us as a matter of urgency before it's too late, because there's much room for improvement here. So please reach out to us. Okay, so I hope that helps. Now, thank you so much for coming on to the show. Thank you for watching. Thank you for your support. Now, if you have a loved one in intensive care, go to intensivecarehotline.com and call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. If you have a loved one in intensive care and you want to go home, especially with long-term ventilation and tracheostomy, you should contact us at intensivecarehome.com. We are currently providing services all around Australia. We are NDIS funded, but also TAC, DVA, iCare, NIISQ, as well as Department of Health funding. Please contact us. Also contact us if you need an NDIS support coordinator, NDIS specialist support coordinator, and so forth. If you need a medical record review, please contact us as well. We review medical records for patients in ICU, but also after ICU. We also provide NDIS nursing assessments. Please also have a look at our membership for families in intensive care and intensive care at home at intensivecaresupport.org. There you have access to me and my team 24 hours a day, and we answer all questions intensive care related. Now, give this video a thumbs up, give it a like, subscribe to my YouTube channel for regular updates for families in intensive care. click the like button, click the notification bell, and comment below your questions and insights and what you want to see next. As I said, if you have a loved one in intensive care and you want to go home with intensive care at home, go to intensivecareathome.com, call us on one of the numbers on the top of our website, or email us to info@intensivecareathome.com. And again, if you have a loved one at home that requires more support, please contact us as well at intensivecareathome.com. Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com and intensivecarehotline.com, and I'll talk to you in a few days. I'll do another YouTube live next week at the same time. Take care, and thanks again.